the coronary angiography will be normal. Epicardial vessels will be normal, or at the most they will show less than 50% lesions in some arteries. This is INOCA. This is more common than it is diagnosed. Greater relaxation of the upper respiratory muscles during sleep causing obstruction. And the main symptom is snoring in the night time and somnolence in the daytime. Laryngopharyngeal reflux is not an uncommon disease disorder, but fairly underdiagnosed. This is one condition that all of us must know about, especially as first responders.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos, so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Welcome, Sanika, Siddhartha, and Ishika. I'm Dr. Tushar Shah, and this is a game of abbreviations. What will happen is this. We will be announcing an abbreviation, and the participants by turn have to give me the full form of abbreviation, and then we will talk about the abbreviation in a minute or so. I'll give you a hint about the abbreviation just in case it seems to be a little difficult. But otherwise, most are very simple, and the audience on their part can write the answers in the comment section. The comments will be visible only to me initially and not to the participants, so you won't be leaking the answers prematurely. So 10 points for the direct answer, 5 points for pass-ons, and if it is possible for you, Sanika, to keep the score, that'll be nice. I'll be keeping it too. So that's Ishika for you. And Ishika, your question will start. Come here. Can you have the first abbreviation, please? Oh, okay. I have to do the movements. Okay. Okay, Ishika, this is about a form of coronary artery disease. It's called INOCA or MINOCA. In MINOCA, it is a disease which is actual ischemic heart disease, but there is something which does not show up in a test. Can you guess what this might be? Okay. Siddharth, can you guess?
Yes, sir.
Yeah, tell me.
INOCA means ischemia with non-obstructive coronary arteries.
Okay, that's excellent, Siddharth. That's 5 points to you as a pass on. I'll just repeat his answer. INOCA is ischemia with non-obstructive coronary arteries. MINOCA is myocardial infarction or ischemia with non-obstructive coronary arteries. Now, this is a condition where the patient will come with chest pain, which is very classic. Will have ECG changes, which are very classic of infarction or ischemia. The patient's drop eye might be positive or strongly positive, and the coronary angiography will be normal. Epicardial vessels will be normal, or at the most they will show less than 50% lesions in some arteries. This is INOCA. This is more common than it is diagnosed, and we must suspect this. We should not label the patient as functional or non-cardiac chest pain if the enzymes are high and if the ECG changes are suggestive. These patients, of course, will require medical therapy. The pathophysiology of INOCA is not very well known, but vasospasm may be a contributing factor to INOCA. So that great answer, Siddharth. Can we go to the next, Siddharth? This is your direct question. What is LPR?
Sir, it is a laryngopharyngeal reflux.
Okay, Siddharth, I hope you're not Googling. That you should not be Googling. At least look at the screen and look at me if you can, so that I'm sure that you are okay. LPR is laryngopharyngeal reflux. Can you tell me what is the symptom of LPR?
Sir, when the patient is falling, is just like GERD, gastroesophageal reflux diseases.
Correct. Okay. Ishika, can you tell me some symptom of LPR which is different from GRD?
No, sir.
No, okay, no problem. I'll elaborate on this. Now, laryngopharyngeal reflux is a not an uncommon disorder, but fairly underdiagnosed. This is one condition that all of us must know about, especially as first responders to outpatients. The reflux is of the same thing as in GRD. It is the reflux of stomach contents, whether it's acid or pepsin. In the condition called gastroesophageal reflux disease, the problem is with the lower esophageal sphincter. In LPR, the problem is with the upper esophageal sphincter, where the contents go into the larynx and pharynx, and this causes very typical symptoms. One symptom is globus pharyngeus. The meaning of globus is that there is a choke or something stuck in the throat. That is one symptom. The second very important symptom is hoarseness of voice. Hoarseness is not seen in standard GRD. Standard GRD has retrosternal burning. In LPR, there is no retrosternal burning unless there is also GRD with LPR. And you have hoarseness and you have the need to clear the throat very frequently. So when many patients will come with repeatedly, this patient you should suspect to have LPR. And the treatment of LPR is similar to the treatment of GRD, but lifestyle changes are very important, meaning propped up position, not eating heavy meals, small frequent feeds, avoiding alcohol and certain beverages, etc. But the PPI treatment remains similar to GRD. So that is LPR. LPR is something that you must diagnose at least once in the next 1 week. Okay, it is common. Laryngopharyngeal reflux. Okay, we go back to Ishika. Ishika, AAA, this is a condition of a large blood vessel in the body and typically occurs in the elderly person, especially males. Can you tell me?
Sir, abdominal artery aneurysm.
Wonderful. Abdominal aortic aneurysm. Aorta being the largest artery that we have. That's 10 points for Ishika. And okay, so important thing. This is an uncommon condition, but an important thing to diagnose because this can suddenly kill by rupturing. How do you diagnose it? What is the investigation? The investigation is ultrasound. In fact, many patients are picked up because of an incidental ultrasound finding. If the aortic artery aneurysm is more than 5.5 centimeters in diameter in males or more than 5 centimeter diameter in females, then this is something that is to be operated or treated with an endovascular procedure. How do you diagnose it? By sonography. So should every person undergo sonography after a certain age? It is commoner in smokers. So everybody who has ever smoked should undergo an abdominal ultrasound between the age of 65 and 75 at least once. Do you know what is the meaning of ever smokers, Ishika? Ever smokers. Ever smoker is a term. You know, never smokers are smokers who are people who have never smoked. Ever smokers are people who have smoked at least 100 cigarettes in their lifetime. So that is an ever smoker. Okay, so that is your AAA. Let's go to the next one. Siddharth, your turn now. Siddharth, your video is off. Can you just switch on the video?
My video is on, sir.
Then you're not moving. You are like a statue. That's nice. You're a calm, collected person. Okay, tell me what does RIND stand for? Okay, we'll pass it on to Ishika. Ishika, what is RIND? Is it related to neurology? If I say R is reversible, I is ischemic, and D would be?
Neurological deficit.
That's right. Reversible ischemic neurologic deficit is RIND. This term is now outdated. It has been forgotten. What is TIA?
Transient ischemic attack.
Wonderful. You know, both of you know that transient ischemic attack. TIA is a term used for any neurologic deficit which recovers within about 1 hour. Though technically it is defined as something that recovers in 24 hours, TIAs recover in 1 hour. And TIAs may present with just a slurring of speech or a hemiparesis or ataxia, etc. The importance of TIA is that you should be able to treat very aggressively and very early, especially in patients whose TIA has a greater risk of a second episode within 48 hours. So there are some TIAs which will recur in a large number of patients. So the risk factors of TIAs are assessed by using a score A, B, C, D. A is for age more than 60, B is for blood pressure more than 140/90, C is a deficit like speech deficit or focal neurological deficit, and D is for diabetes. ABCD is a score used for predicting whether a TIA will be followed by a larger stroke. So you should learn this. And the importance of this is that if you get a patient of TIA, if the score is high, this patient has to be immediately hospitalized. Most patients of TIAs have to be hospitalized. Okay, so that is your TIA for you, or a RIND. Now, this is Ishika's turn, I think. Ishika, PICC. This is something like a line, a long line put into the arm, upper limb.
Pass, sir.
Siddharth?
Yes, sir.
Pick. Okay, we pass it on to the audience. I think audience has given me some answers. No, audience has not given me answers. This is something that family physicians don't know about, and this is important because now many patients will be managed with a peripheral line at home, meaning some patients who have, say, on chemotherapy for long durations, patients who are on antibiotics for long durations, for example, pyelonephritis, which is bad, or transplant-related infection. These patients will be discharged often from a hospital with a PICC line, peripherally inserted central catheter, and the family physician will be supervising the catheter. Right? Wonderful. Let's go to, whose turn is it now? Siddharth? Siddharth, HEF-PEF. Not very difficult.
Ejection fraction.
Siddharth ka hai?
Yes, sir. Sir,
If
heart failure, ejection fraction.
Very good. Heart failure with what ejection fraction?
Sir, when normally, sir, when we have ejection more than 50%.
I agree with you. 50% at least ejection fraction is preserved ejection fraction. Can you tell me what is the cause of such heart failures? Why would a preserved ejection fraction cause heart failure?
As a hypertensive patient associated with comorbidities, sir, diabetes, hypertension, thyroid disorders. It's like
Perfect. The three major risk factors for HEF-PEF are hypertension, age,
chronic disease also.
chronic disease, but the three most important are hypertension, old age, and obesity. These are three most important HEF-PEF risk factors. Right? Wonderful. We go on to Ishika again. Ishika, what is MP, MRI? MRI, you know, right? What is MP? If M is multi, what is P?
Para
Something, yes.
Parametric.
Sorry?
Multiparametric prostate MRI.
Multiparametric MRI typically done for. Very good, Siddharth. Typically done for what? So prostate.
Prostate carcinoma.
Correct. It is one of the principal uses of multiparametric MRI is to look for the prostate pathologies that are missed on CT scan or ultrasound. And the commonest pathology that we are looking for is prostate cancer, and this MRI will help us find a place from which to biopsy the prostate. It will localize the
Right.
lesion very well so that we can biopsy that lesion. Prostatitis, of course, will be visible also
This
on an
means a
MP
pretty
MRI.
aided MRI.
Multiparametric basically means multiple sequences are used in this MRI. So this is a very useful, very sensitive test for small prostate cancers. Excellent. Ishika, the hint is,
Just
do you know this?
lung injury. Sir, is it related to lung injury?
It's another organ, not lung.
Okay.
I'll give you hints: antituberculous therapy and paracetamol.
Drug-induced liver injury.
Wonderful. 10 points to you, Ishika. Drug-induced liver injury. Now, the most common drugs causing DILI in India are anti-tuberculous drugs. Can you name 3 anti-tuberculous drugs which cause liver toxicity?
Yes, sir. Rifampin, pyrazinamide, ethambutol, and isoniazid.
No, ethambutol is incorrect.
Ethambutol causes optical.
Correct. So this INH, rifampicin, and pyrazinamide are the 3 commonest causes. And which is, do you think, Siddharth, is the commonest cause of DILI in the US, in the United States?
Infection, hepatitis.
Paracetamol. Paracetamol poisoning, in fact, is the commonest cause. Right? Wonderful. Another common and important cause is CAMS, complementary medicines, that is complementary and alternative medicines can cause DILI. Right? Ayurvedic medicines, 18% of DILI are caused by Ayurvedic medicines. Okay, so that is DILI for you. Let's go to Siddharth. Siddharth, your EUS.
Endoscopic.
Wonderful. Endoscopic.
Endoscopic ultrasound, sir.
Endoscopic ultrasound is the correct answer. Siddharth, can you tell me what is it used for?
Sir, when with a patient with esophagus or stomach injuries, intestine injuries, we have to do endoscopic ultrasound to visualize.
Correct. So endoscopic ultrasound is a gastroscopy or esophagoscopy with ultrasound apparatus. For example, if you want to biopsy,
tumors or like that, lymph nodes.
Correct. If you want to biopsy lymph nodes, look at lymph nodes, or you can want to look at a pseudocyst of the pancreas through the stomach and aspirate the pseudocyst of pancreas. If you want to look for a CBD stone, which is not easily visible, if you want to see a pancreatic stone, which is not visible, then you will do endoscopic ultrasound. Excellent. Do you know the full form of EBUS? EBUS? EBUS is endobronchial ultrasound, like bronchoscopy with a probe that will do ultrasound. And do you know EVUS? EVUS?
Vascular.
Wonderful. Endovascular ultrasound. And for example, during angiography of the heart, coronary angiography, we can look at the plaque through an ultrasound and decide on whether stenting is necessary or calcium is very loaded with calcium so that we can do rotablation, etc. So that is your EBUS, EUS, and EVUS. Let's go to the next. And this is, I think, for Ishika. Ishika, what is NERD? If GERD is gastroesophageal reflux disease, what is NERD?
It's definitely a reflux disease, sir.
Wonderful, wonderful. Half points to you. What is NE? Tell me.
It's like there are two erosive or non-erosive. It's like a non-erosive reflux disease.
Wonderful. Non-erosive reflux. So GERD can be erosive or non-erosive, and this is non-erosive reflux disease. Excellent. The important thing about NERD is that
erosive esophagitis.
Yeah, your voice is not clear. Can you repeat that, Siddharth?
Sir, it is differentiating feature from non-esophagus, erosive or non-erosive esophagitis.
Correct. So non-erosive reflux disease does not predispose to Barrett's esophagus, which is the pre-malignant condition, or
On the side.
to malignancy itself. So NERD is a little better than GERD in that sense. Symptomatology and treatment are nearly the same.
Hmm.
Okay. Now, Siddharth, your question. What is UBT?
So UBT.
Okay, we pass it on to Ishika.
Urea breath test.
Wonderful. Urea breath test. Siddharth, what is urea breath test used to diagnose? Ishika?
Sir, uremic state.
No. Urea breath test is to diagnose H. pylori active infection. Active
Yes.
infection of A with H. pylori. Do you know where does H. pylori reside? Where does H. pylori reside?
In the bowel, stomach,
In
and
the pylori means pylorus, right? It's in the stomach, in the pylorus of the stomach typically. And H. pylori is the cause of what?
Sir, in case of ulcer and gastritis patients.
Wonderful. H. pylori can cause erosive gastritis
Mostly
or
encountered cases
peptic
when I
ulcer.
work in some normally encountered cases when I work in district hospital Mathura. Normally,
Okay.
sir, cases common.
Okay.
H. pylori cases happen.
So how do you diagnose? Which test do you diagnose in Mathura?
Sir, just like sir, sir, urine exam, urine RM, protein microscopy, pus cell examination, सारी चीज सर हम कराते हैं.
Take a minute, I'm a little confused. You're talking about what? Which condition?
Sir, UBT.
Oh, UBT is not diagnosed by pus cells, etc. UBT is diagnosed by a stool antigen test, which is very typical. Urea breath test, which requires a radioisotope of carbon, and it can be diagnosed by antibody test in the blood. The commonest test is the stool antigen test for H. pylori. Another test is an endoscopic test where you put in an gastroscope, and you test the small biopsy from that area on a disc where that disc is rapid urease test disc, RUT. So these are the ways to diagnose H. pylori. And then H. pylori, if necessary, H. pylori is present in a large number of people and does not necessarily cause disease. So you don't have to treat all patients who have H. pylori positive. You have to clinically correlate. If the patient has a peptic ulcer, you will treat that patient with antibiotics for H. pylori. Wonderful. Let's go to the next slide, and this is for Ishika. Can you tell me what is SMA syndrome?
Superior mesenteric artery syndrome.
Wonderful. Superior mesenteric artery syndrome. It's an extremely rare condition, but I have included this here for one reason. Superior mesenteric artery lies between, one part of superior mesenteric artery lies between the third part of duodenum and the aorta. And in the SMA syndrome, the artery is compressed between these two. When it is, sorry, I'm so sorry. I'm very sorry. The duodenum is compressed between the superior mesenteric artery and the aorta. And when the duodenum is compressed, what do you get symptoms wise?
Obstruction.
Obstruction, therefore vomiting and severe abdominal pain, right? So you get an acute abdomen with vomiting in SMA syndrome where the artery and the aorta are squeezing the duodenum between them. This occurs typically in younger patients, and it occurs in people who are tall and thin, especially. Also, it occurs in patients who are losing weight rapidly, which is the reason why I have included this. Today, what new medications have come that make people lose weight rapidly?
Sir, I know this one. That the one which we use for diabetes control.
Wonderful.
Wonderful.
GLP-1 receptor agonists. GLP-1 receptor agonists. For example, Siddharth, you were saying something?
GLP-1, sir.
Mounjaro is a brand name, or Ozempic is a brand name.
Ozempic.
Mounjaro is tirzepatide and Ozempic is semaglutide. These are two GLP-1 RAs which cause weight loss. SMS syndrome can occur in those who are getting rapid weight loss. Okay, so that is your SMS syndrome. Siddharth, your turn.
Yes, sir.
Sir, your voice.
Tushar sir, your voice is muted from the right hand side. We can't hear you.
Okay, I'll repeat the question. CIC. What is CIC?
It's a clean intermittent catheterization.
Wonderful.
Patient with chronic idiopathic constipation, we have to do the draining the bladder. It's a procedure for draining the bladder.
Okay, so you have mixed two
Catheterization.
abbreviations or two full forms. I'll give you both the full forms. CIC, clean intermittent catheterization, is one full form, and a separate full form is chronic idiopathic constipation, right? And here we are talking about chronic idiopathic constipation. And what is the first line treatment of CIC? The first line treatment is always non-pharmacologic. The first line treatment is plenty of fluids,
Fluids.
timing your bowel movement at a specific time every day, and raising the legs on a stool if you are using the English kind of toilet. These are the first line. Second line therapies are the products that are fibers. For example, carbohydrate laxatives or isabgol like fibers, or even the PEG, that is polyethylene glycol. So CIC, chronic idiopathic constipation. Okay, whose turn now?
Mine.
Ishika. And I'm okay, great. I can see you much better, Siddharth, now. Great. Your question, Ishika. What is SBP?
Sir, subperitoneal bacterial subendothelial bacterial peritonitis.
S stands for spontaneous. You got that mostly right. Spontaneous bacterial peritonitis. The meaning of the word bacterial peritonitis is obvious. Infection in the peritoneum with ascites usually. And what is spontaneous? Spontaneous means that it is not due to any trauma or any injury from somewhere. It is spontaneous. SBP occurs typically in cirrhotics who have ascites. And if a cirrhotic patient develops SBP, what is it an indication of? Something that you have to do drastic.
No. What
Any
is that?
patient of SBP, the first episode of SBP itself is an indication for liver transplant. You must go ahead with workup for liver transplant and put that patient on the transplant list, because if once SBP occurs, the 1 year mortality without transplant becomes very high. Right? That is SBP. Wonderful. Now we go to Siddharth.
Yes.
What is PIVCA? This is a little difficult, and I'm so sorry that I have to give you this, but I have to give you a hint. PIVCA is a protein induced by vitamin dash absence. What is K?
The vitamin A is just like antagonist. When we manage with a patient with hepatocellular carcinoma, it's just like liver cancer. Workup.
Wonderful. PIVCA is a marker for liver cancer. Just like alpha fetoprotein is a marker for liver cancer. PIVCA is a protein induced by vitamin K absence. In liver cancer, liver is a producer of vitamin K. In liver cancer, vitamin K production decreases. This decline in vitamin K production increases the level of something called PIVCA2, which is a marker like alpha fetoprotein is a tumor marker for HCC. PIVCA is especially useful in patients who have undergone treatment for HCC and you want to look for recurrence. If recurrence occurs, PIVCA will rise faster than alpha fetoprotein. So PIVCA often has a greater utility than alpha fetoprotein, or both are done often together to get a better picture of cancer. That is PIVCA.
Especially, I know PIVCA, that's I am dealing with patients with HIV or hepatitis in district hospital Mathura. That's
Oh,
why I
wow.
am doing this marker.
You are familiar with the marker.
Mm,
That's amazing. Amazing. PIVCA is expensive, but it is possibly a
yeah,
little better than
possibly.
alpha-fetoprotein.
Sure, sir. Thank you.
Okay, this is a statistics term. And can you tell me what is ARR and RRR, Ishika? Ishita?
Those are ours, please.
Okay, statistics.
Mm.
Risk reduction. RR means risk reduction. What is ARR?
RRS are absolute risk reduction and
And
relative risk reduction.
wonderful. Relative risk
It's
reduction.
in use in clinical trials.
Wonderful. And which one of these is a better judge of efficacy of a drug?
Sir, ARR.
ARR, absolute risk reduction, is far better than RRR. When you read statistics and when you hear statistics,
Yes.
especially when a medical rep comes to you and says, okay, sir,
Yes.
the absolute risk reduction of hepatocellular carcinoma with this drug is 50%, and you will be very impressed. Oh, 50% reduction in risk. But ARR is the important thing. RRR is not the important thing. RRR is a misleading feature. Can I give an example? It's slightly complicated. Okay, this is a true example. If in a trial where atorvastatin was given for primary prophylaxis in patients for 3 years plus, what is primary prophylaxis? That the patient never had any atherosclerotic cardiovascular disease. When atorvastatin was given for primary prophylaxis, the risk reduction was 31%. Are you impressed with that risk reduction? 31%, that was the relative risk reduction. 31% was the relative risk reduction. So not impressive. The absolute risk reduction was 1.1%. Only 1.1% people really benefited in absolute terms. ARR gives you what is called the numbers needed to treat, NNT. Do you know that concept of NNT? If you give 100% atorvastatin for 3.5 years, you will save one person from a myocardial infarction. That is NNT. So in this study, ARR study, where the absolute risk reduction was 1%, the numbers needed to treat became 99 or something, because ARR ka inverted ratio is NNT. I'll not go into more details because I'll have to show you a chart. But just to again emphasize, ARR is the key statistical feature in knowing whether the drug is efficacious or not. Okay, let's go to the next one. Siddharth, what is MRSA?
Sir, MRSA is a magnetic resonance.
Okay, Ishika, you know.
Methicillin resistant Staphylococcus aureus.
Wonderful. Methicillin resistant Staph aureus. Now, can you tell me what is MSSA?
Methicillin sensitive Staph aureus.
Which is better to have an infection with?
Sir, MSSA.
Is better. MRSA is worse because drugs are often ineffective. Can you tell me a few drugs that will be effective in MRSA in the outpatient, OPD?
Vancomycin.
OPD. Vancomycin is an injectable for MRSA in the OPD. You get a patient who has cellulitis, diabetic patient. There is pus oozing from the leg. You collect the pus, do a swab, you find MRSA. What antibiotic may be useful? One very straightforward antibiotic is doxycycline. The other very commonly available antibiotic is cotrimoxazole, that is trimethoprim sulfamethoxazole. The third antibiotic, which is less used, is clindamycin, oral available. The fourth antibiotic that is also less commonly used is linezolid. These are the 4 oral antibiotics. And the parenteral antibiotic, one of them, as you said correctly, is vancomycin. Then there is linezolid IV available, clindamycin IV available, and there are many more. So yeah, wonderful. This is MRSA. And one important thing about MRSA is MRSA can cause recurrent boils, recurrent pus lesions in the skin or subcutaneous tissue, SSTI. You know what is SSTI? skin and subcutaneous tissue infection. SSTI due to staph aureus can occur again and again because MRSA and MSSA both are carried in the nostrils, and the patient from the nostril rubs the organism onto the body parts. Therefore, as a preventive, these patients are asked to apply mupirocin ointment in the nostrils twice a day or so for several days to sterilize the nostrils. This is especially done before major surgeries to prevent MRSA infection after, say, knee replacement or bypass, etc. Okay, so that is your MRSA. Now we go to Ishika's turn. Your PEG related to feeding. What is PEG?
PEG.
Related to feeding.
Feeding, sir.
Feeding.
Is it a gastrostomy or something?
Wonderful. It is an endoscopic gastrostomy. It is a percutaneous endoscopic gastrostomy. Wonderful. Can you give me one indication of that?
So when a patient for enteral nutrition.
Malnutrition.
Just like cancer patients, sir.
Cancer patients, for example, they have obstruction of the esophagus and you want to give enteral nutrition. A Ryle's tube cannot be placed. You will give a PEG tube. Similarly, if the Ryle's tube is required for very long, you can't give a Ryle's tube for very long. Therefore, sorry?
Neck cancer. Head and
neck. Yeah, any obstructive cancer here, you might have to place a PEG tube. Any patient with motor dysphagia, for example, patients with Parkinson's or Alzheimer's or motor neuron disease may get dysphagia, which is not mechanical but motor, peristalsis. These patients may have to be given a PEG tube. This is the PEG. And the other PEG, is polyethylene glycol, which we already talked about in constipation. Do you know the dose of polyethylene glycol in acute constipation? How many grams? It's a powder often. How many grams of the powder? 17 grams. Just remember this, 17 grams single dose for chronic constipation or acute constipation. But if the constipation is very severe and there is what is called as obstipation, meaning obstructive constipation, or what we call fecal impaction, then the dose is 8 times the usual dose. So it is not 17, but 136 grams diluted in water at a time, given slowly over say half an hour or so 1 hour. So that is PEG for you. And the other PEG we just discussed was percutaneous endoscopic gastrostomy. Okay, let's go to Siddharth. What is CRE? This is related to bacteriology, and this is related to drug resistance.
Enterobacterials.
Wonderful. Carbapenem resistant enterobacterials. Enterobacteriaceae was the old term. Enterobacterials is the new term. The commonest enterobacterial is, say, E. coli. So there are many carbapenem resistant gram negatives, and they are quite disastrous because the mortality rate is very high. So our antibiotics available for CRE are very few, like for example colistin. Okay, let's go to Ishika. Your turn. With respect to respiratory disease, obstructive respiratory disease, what is ACOS?
Asthma related, sir. It's asthma, COPD. It's both asthma and COPD.
Wonderful. Both of you know that. Asthma, COPD overlap syndrome. Excellent. Asthma, COPD overlap syndrome basically means that the patient has fixed obstructions also, like in COPD, and also some dynamic obstructions which can be dilated after bronchodilators. And that's why these patients are given triple drugs, usually 3 drugs. What are the two drugs used in asthma typically? What are 2 types of drugs used together in asthma?
Sir, inhalational steroid and butanol. Sorry.
Beta agonist. That is a LABA, long-acting beta agonist, and ICS. ICS means inhaled corticosteroids. What are the 2 drugs typically used in COPD? LABA again, long-acting beta agonists like salmeterol or formoterol, and Lama. What is lama?
Long
Muscarinic antagonist. Long.
Example?
Long.
Tiotropium. Tiotropium is a long acting. So you can use a combination of LAMA, LABA in COPD and ICS, LABA in asthma, and in ACOS you will use all three. ICS, LABA and LAMA. Okay. That is asthma COPD overlap syndrome. Okay, now we go on to Siddharth. Siddharth, what is OSA?
Is a obstructive sleep apnea.
Wonderful. That was easy. Obstructive sleep apnea.
Disorder.
What is the principal symptom?
So main apnea is when the muscles are not, throat muscles are properly not relaxed. It means leading to pose the apnea.
Actually, उसमें relaxation ज़्यादा हो जाता है. The relaxation so much that the tongue falls back, the pharynx closes. So greater relaxation of the upper respiratory muscles during sleep, causing obstruction. And the main symptom is snoring in the night time and somnolence in the daytime. Daytime somnolence, nighttime snoring, right? Okay, great. Now we go to the next one, and that is for Ishika. Ishika, what is VCTE? I'll have to give you a hint. It is used in liver. It's a test used in liver.
Sir, I pass.
Okay, anybody?
It's a vibration controlled transient elastography.
Wonderful. Vibration controlled transient elastography. And what is it? What is the brand name of one such machine? Fibroscan. Very commonly the used term is Fibroscan. Fibroscan is a brand name of a machine that does elastography of the liver. Just like we use the word Xerox. Xerox is actually a brand name of photocopying machines. So brand name for elastography is Fibroscan. What is it used for? Would you know? It is used to measure fibrosis within the liver in high-risk patients who might progress to cirrhosis. When cirrhosis is you have a patient who, say, sonography is done, the sonologist reports grade 2 fatty liver, or blood test is done and SGOT, PTR 50 and 60. And then you would want to test for fatty liver and especially for fibrosis within the fatty liver. Because fibrosis is the pathology which can be only otherwise diagnosed on biopsy. So we have elastography to indirectly measure fibrosis. Right. Another important fibrosis indicator is what is called the FIB4 score. FIB4 score. FIB4 score basically is where SGOT, SGPT, and platelet count are put into a calculator to calculate the score. Right. The higher the FIB4 score, the greater the chances of you having fibrosis. This is a good score to calculate as an initial screening tool in patients, say, who are alcoholics, who have hepatitis C, hepatitis B, or just obesity-related MASLD. What is MASLD? MASLD. It's a new term for fatty liver disease.
It's a metabolic related.
Metabolic dysfunction associated liver disease, MASLD, right? It's an important disease because it can lead to cirrhosis and hepatocellular carcinoma. Metabolic dysfunction related means it is not an alcoholic liver disease. It is a non-alcoholic liver disease. Wonderful. Let's go to the next one. VCTE. Now EOE. Siddharth, what is EOE? Okay, Ishika, any idea?
Sir, EO like eosinophil.
Wonderful. EO is eosinophil. And E is esophagitis. American EA. Eosinophilic esophagitis. This is an uncommon condition, but with a very interesting treatment. Eosinophilic esophagitis presents typically with same symptoms like GERD, occasionally with also dysphagia. sometimes retrosternal pain, burning. And here the diagnosis is very difficult. But if you have a patient with GERD symptoms who does not respond to PPI, you may want to suspect EOE. Diagnosis is by doing a biopsy. Do an endoscopy, do a biopsy from the esophagus, and you see, look for eosinophils on the tissue. Who do you suspect this with? Those who have not resistant GERD symptoms, and also those who have GERD symptoms with other forms of atopy, other forms of allergy, like allergic rhinitis, like urticaria, like asthma. These patients are more prone to eosinophilic esophagitis, and the treatment is very fascinating. In eosinophilic esophagitis, you have to take steroids which act locally in the esophagus. So what will you do? You will take a budesonide inhaler that is used for asthma. Spray some sprays into make it a slurry using honey. In honey, put some inhaler of steroid and then ask the patient to slowly drink that honey. It will go into the esophagus and that steroid will treat your esophagitis. A very peculiar thing, but of course, any patient of eosinophilic esophagitis should be, when suspected, should be referred to a gastroenterologist. Wonderful. Let's go to the next one. Now we have only two left, I think, 2 or 3 left. EVALI. If E stands for e-cigarettes and V stands for vaping, Siddharth, what does ALI stand for?
सर ई सिगरेट वेपिंग प्रोडक्ट्स यूजिंग एसोसिएटेड लंग इंजरी के साथ हम यूज़ करते हैं पेशेंट्स के साथ, जो ओएसटी वाले पेशेंट्स होते हैं ना सर, ओएसटी वाले।
आपके गांव में कितने लोग वेपिंग करते हैं?
सर मेरे यहाँ, सर हमारे इधर तो बहुत मोस्ट कॉमनली सर ट्यूबरक्लोसिस कॉमनली एनकाउंटर्ड पेशेंट्स आते हैं मोस्टली सर 75%।
मतलब बीड़ी सिगरेट वाले हैं कि वेपिंग वाले?
सर वेपिंग वाले थे ना, वैसे बीड़ी सिगरेट वाले हैं कॉमनली।
बीड़ी सिगरेट नहीं, मैं ये वेपिंग अलग चीज होती है। आप जहाँ रहते हैं ऋषिका, वहां पे कितने लोग आपकी कॉलेज में वेपिंग करते हैं?
सर आई मीन सर मेरे कॉलेज टाइम पे तो लोग करते ही थे, लाइक राइट नाउ आई
Okay, so e-cigarettes and vaping associated lung injuries are a reason why you should dissuade youngsters from vaping, because lung injuries can be very acute, like in the form of pneumonia, chemical pneumonia, or you can have fibrotic lung disease also. Long-term lung involvement can occur. Usually, these injuries are related to the things that are added to the nicotine. For example, you will be surprised, vitamin E is added as a thickening agent to the vaping liquid. And vitamin E taken as an inhalant is a very toxic drug for the lungs. So that is EVALI. Let's go to the next one. And this will be for, I think, Ishika. Yes. What is ULABA? No. If UL is ultra long.
Ultra long acting beta agonist.
Wonderful. Ultra long acting beta agonist. These are again drugs typically used in asthma or COPD. They are longer action than 24 hours. And can you give me an example of a ULABA?
Sir,
do you know any drug?
Just you told salmeterol.
No, that is a LABA. Salmeterol and formoterol are LABAs. ULABA is longer acting than both of them. Vilanterol is one example. Vilanterol and umeclidinium is another example. So I might be spelling that wrong. Umeclidinium and vilanterol are ULABAs. That is, and we have combinations of ULABAs with steroids or with steroids and muscarinic antagonists. ULABA. Okay. Siddharth, what is NSIP?
So it's just like pneumonia, sir. Interstitial, non-interstitial pneumonia.
Okay. So this is non-specific interstitial pneumonia. Now, the subject of interstitial lung disease is very difficult. In fact, even after reading it again and again, for me, at the age of 63, I still cannot fathom everything about interstitial lung disease. But for us to know a few conditions is important. One condition amongst interstitial lung disease that we should know about is IPF, idiopathic pulmonary fibrosis, which is clinically diagnosed with CT scan support. And this is important to diagnose because there are two drugs at least that are used for IPF. One is nintedanib, and the other is pirfenidone. These two drugs are used for IPF. Similarly, NSIP is a drug where principally steroids are indicated. And NSIP is something that occurs with underlying diseases, especially connective tissue disorders like rheumatoid arthritis, like scleroderma. That is NSIP, where steroids are more useful. And now in IPF, we know that steroids are not to be used in IPF. Okay, so it is very important to classify the interstitial lung disease. Okay, let's go to thank you. Okay, I'm sorry. That was the end of the quiz. Thank you so much. Both of you, thank you for participating. Both of you get a German-make blood pressure instrument from a company called Hein, which I think is the best BP instrument in the OPD that one can use. We will send them to you by courier, hopefully by the end of the month. Thank you.
Thank you, sir.
Most
Thank you so much, sir. It's my
Most
pleasure.
welcome. Okay. Yeah. Is Sanika there?
Sir, and thank you so much, Dr. Ishika and Dr.
Thank you.
today for this quiz.
Okay. Sanika, do you want to take any questions? I don't think there'll be many questions. I have asked too many questions already.
Yes, sir. There are no questions, but there have been appreciative comments for the teaching and the session in general in the comment section.
Wonderful. And all credit to Siddharth and Ishika.
And to you, sir. The questions were really good.
Sir, to
I
join
get
with
to know about a lot of things that I didn't know.
Wonderful. I'm so glad, and I hope that you can make a quiz similar to this with abbreviations for your classmates or batchmates or your colleagues within your vicinity. But thank you so much.
Thank you.
Thank you, sir.
Yes, sir.